Dirk Blom. I'm working at Cardiology Hospital in Cape Town, and I'm the head of the Division of Lipidology at the University of Cape Town, and essentially I run our local lipid clinic.
We asked Dr. Blom to tell us about the growing problem of heart disease in South Africa.
So South Africa has always been known as a country with a high prevalence of familial hypercholesterolaemia in certain population groups. So we have that problem of high cardiovascular disease rates, mainly in white Afrikaans speaking community, and that's been a problem that's been known for a long time. We are seeing a lot of cardiovascular disease in our Black African population with urbanization and change in diets, so it's becoming a real problem. We have a lot of diabetes in that group as well, and in fact the diabetes rates are increasing, so the cardiovascular epidemic is waiting for us, and I think it's only going to get worse. In our Indian community, we also have a lot of insulin resistance, a lot of diabetes, and quite high cardiovascular disease rates. So we are doing what a lot of the developing world is doing. We're following a trend of increasing cardiovascular disease, and it's certainly no longer a disease of affluence. In fact, it's a disease of poverty in many instances. The other chronic health issue that's a major issue here, obviously HIV infection. And those two epidemics overlap to a degree because antiretroviral therapy often does have metabolic side effects. It does increase the risk of diabetes, dyslipidemia occurs.
Familial hypercholesterolemia is also a major related problem, he explained.
Familial hypercholesterolemia is a really big problem in South Africa for us that we need to work on quite hard to manage better than we are doing at the moment. So we have founder effects for familial hypercholesterolemia, and we've got three well-described founder populations. So the first one is the white Afrikaner population, where we have a founder effect, and the prevalence of familial hypercholesterolemia, depending what data you look at, is about 1 in 70 to 1 in 100. Classically, we used to say the prevalence in the rest of the world is about 1 in 500, but newer data from Denmark and from the Dutch is suggesting that that was an underestimate. It's probably 1 in 200 to 1 in 300. Then we have an Ashkenazi Jewish population with a lot of Lithuanian immigrants. And in fact, it's the FH Lithuanian mutation that's very prominent in that community. And we have a third founder population with Indians from Gujarat. So we have these three populations with founder effects, and obviously high prevalences of familial hypercholesterolemia, which then of course also leads to a very high prevalence of homozygous familial hypercholesterolemia, because the populations have not tended to intermingle much. And if you have a 1 in 100 sort of prevalence, then it's not that unusual for a heterozygote to marry another heterozygote. Often one of the partners is undiagnosed, and then there's obviously a 1 in 4 chance of that couple having a child with homozygous familial hypercholesterolemia. So we see a lot of patients with homozygous familial hypercholesterolemia compared to the rest of the world, and we're still not identifying all our FH patients early enough to give the correct kind of counseling, make people aware of the risk of having a child with homozygous familial hypercholesterolemia. The Dutch have had a program that was supported by the government involving genetic testing of probands, followed by cascade screening in families using genetic nursing services, family tracing, and with that they've actually managed to probably identify the majority of familial hypercholesterolemia patients in their country get them onto treatment early, and with that prevent a lot of cardiovascular disease. Unfortunately, we don't have genetic tracing services, so we do the best we can from a clinical point of view, trying to get the family to come in. There's obviously been a lot of debate in the UK about the new guidelines. This is a group of patients where the evidence is quite clear and unambiguous. These patients need and deserve primary prevention. They have extremely high LDL cholesterol, so they don't need other risk factors. They will get coronary artery disease at a young age in the vast majority of cases if left untreated.
How do we best go about identifying these high-risk FH patients?
We obviously need our medical students, junior doctors, to do a comprehensive risk assessment. So we want them to ask about smoking, often forgotten or neglected, but a very, very powerful risk factor. Look at the diabetes, look at the blood pressure, but then with the lipids, they need to realize that if you are looking at lipids taking a few days after myocardial infarction, you may see an acute phase response, so you may miss a significant hypercholesterolemia. We want them to look at the family history, see is there an autosomal dominant pattern of cholesterol issues and premature cardiovascular disease, and then clinically looking for the signs associated with familial hypercholesterolemia. The most valuable sign is obviously a tendon xanthometer. Those are most commonly found in the Achilles tendons or the extensor tendons of the hand. If you don't palpate those tendons, you may miss the xanthoma. Unfortunately, xanthoma are not uniform. Not all patients have xanthoma, and they tend to increase in prevalence as patients become older. But if you do find a xanthoma, that's a very clear indication that this patient's got a genetic disorder of lipid metabolism, so it is worthwhile looking for them. Xanthelasma are less useful clinically. They often occur in patients who don't have marked hypercholesterolemia, but once again, if you see them, if you haven't tested the lipids, you should. Arcus in a young patient, young being arbitrarily somewhere under 40 to 45. Again, a little warning sign, go check the lipids, but absence or presence doesn't help you make a diagnosis of familial hypercholesterolemia. So in our country, it's an awareness of the founder populations. It's a careful look at the family history, and a look at the family history that goes into a little bit more detail than just asking, did your mother have high cholesterol? Well, she may have had a cholesterol of 5.6 and her GP said to her that's a little bit too high. Did she have cardiovascular disease? Well, I think it's very important whether the mother had the myocardial infarction at the age of 48 or 83. So we just need a little bit more effort put into that family history, then look at the clinical signs, and then very roughly we tell our medical students once the LDL is 4.9 to 5, you're in the territory of genetic dyslipidemia, so you should be very aware. Not all those patients with familial will have familial hypercholesterolemia. Some may have familial combined hyperlipidemia or some other slightly polygenic form. But I'm very glad to see that the new US guidelines have actually formally recognized an LDL of 4.9 as an indication for treatment. And that's kind of what we've actually been teaching our students for a long time, is that LDLs of 4.9, your standard Framingham-based risk assessments may be misleading, often underestimate the risk, and you should seriously consider treatment in all of those patients. And then the last thing we try and teach people is that once you're talking about genetic dyslipidemia, you move away from the area of you just have a patient that you're dealing with. You actually then have a family that you're dealing with. So we need to get that into our education system a little bit more, that you may have an index case, but you can't just concentrate everything on that. You have to ask about the brothers, the sisters, the children, who else in the family is at risk. So that if we don't have a formal cascade screening system, we still do the best we can as clinicians to try and identify other patients at risk and get them therapy.
We asked Dr. Blom to outline strategies for the treatment of FH based on the South African experience.
For many patients with familial hypercholesterolemia, statins on their own won't achieve target LDL levels. It obviously depends on the baseline LDL cholesterol, because we'll see some patients with familial hypercholesterolemia who come in with an LDL of 4 or 4.5, but some of them may have an LDL of 10 or more millimoles per liter. And then the response to treatment obviously varies as well. So some patients will be adequately controlled with statins, but a lot of patients won't be adequately treated. For those patients, the options that we have to treat them are ezetimibe, which is the cholesterol absorption inhibitor. That combines well with statins and is usually well tolerated, gives you a worthwhile extra LDL reduction. In our practice, ezetimibe is the first choice as an additional agent for patients with familial hypercholesterolemia. Other options are obviously bile acid sequestrants, either cholestyramine or cholesevelam. Both agents are actually currently not available in South Africa. There is some data showing that triple therapy, high-dose statin plus ezetimibe plus a bile acid sequestrant, does give you a further LDL reduction compared to just double therapy. So for very severe patients, one would consider that as a treatment option. Fibrates we generally don't use in these patients because they have an LDL disorder, and fibrates are not very good LDL lowering agents. And the next step would be apheresis, some form of lipid apheresis. Now that's obviously an expensive therapy and it's not widely available at all. So we have that available for a few patients with homozygous familial hypercholesterolemia, but we haven't been offering lipid apheresis to severe heterozygotes.
What treatment advances are in store for the future?
The biggest development on that field has certainly been PCSK9 inhibitors. And PCSK9 is relatively recently discovered protein. It's secreted mainly by the liver, and essentially what it does, once it's secreted and it's in the circulation, it can bind to hepatic LDL receptors. If an LDL receptor with PCSK9 bound to it is internalized, that LDL receptor is not recirculated to the cell surface. So having a lot of active PCSK9 available means you have fewer LDL receptors, and with that, high LDL cholesterol. In fact, PCSK9 was discovered as another genetic cause of the familial hypercholesterolemia phenotype. And subsequently, we've also found patients with loss of function mutation in PCSK9, and they're very lucky. They have low levels of LDL cholesterol and markedly lower rates of cardiovascular disease than their peers who don't have these loss of function mutations. The therapy that's most advanced is obviously monoclonal antibodies. And there's several pharmaceutical companies working on these antibodies, and they're fully human antibodies that basically bind to PCSK9 and you take it out of the equation. So you give patients something akin to a loss of function mutation, upregulate their LDL receptors, and with that you get profound LDL cholesterol lowering. And if we look at the FH experience with the various antibodies, generally the patients that have gone into the trials have been the difficult to treat patients. The vast majority of them have been on top dose statins. About 60 to 70% have generally been on ezetimibe as a second agent. And depending on what data you look at, the LDLs have been 3 to 4, despite this quite aggressive therapy. And adding in the monoclonal antibody gives you anything from a 50 to 65% further LDL cholesterol lowering. So for the first time, you're actually seeing a lot of patients with familial hypercholesterolemia reaching their targets, having good LDL control. So it's certainly a very effective lipid lowering therapy. We also know it lowers lipoprotein a, which a lot of the other lipid lowering agents don't affect. The data to show that lowering lipoprotein a reduces events is quite sparse, but certainly lipoprotein a is becoming quite interesting. So it's quite good to see that that's being lowered by these drugs as well. The PCSK9 monoclonals don't really change HDL cholesterol to any significant degree. So we're getting a lot of extra LDL lowering.
Dr. Blom then went on to describe tolerability and safety monitoring features with these new agents.
From a safety point of view, certainly in the short 12-week studies, we're not seeing any major patterns emerging that suggest that there are problems with these drugs. Looking at liver safety, we're not seeing increased transaminases, we're not seeing muscle effects. There has been an issue raised by the FDA about possible neurocognitive effects of this profound LDL lowering. Most of the studies were not really geared up to examine neurocognition in great detail. They didn't include neuropsychological testing. So all one can really do is go back and look at the adverse event reporting of dementia, confusion. At the moment, from my reading of the literature, the neurocognitive, there's no signal that is worrying me that these drugs have significant neurocognitive adverse events. So overall, these drugs are well tolerated by patients, although they're subcutaneous injections, but they're usually given once every 2 weeks or once a month. Those are the dosing regimens that have been looked at the best in most of the studies, and patients accept those injections fairly well in my experience.
Are there any outcome data from trials of the new agents, or is it too soon to expect these?
The million-dollar question is obviously, is this LDL cholesterol lowering going to translate into a further reduction of cardiovascular events? And for that, we really have to wait for the outcome studies. There's 3 major companies involved in this field, and in fact they all have ongoing outcome studies. These studies differ slightly. They're either looking at the post-acute coronary syndrome population or a more stable sort of chronic atherosclerotic cardiac disease population.
Will these newer agents be used in statin intolerant patients also?
For me, these trials have actually been very interesting because they've shown us a lot about statin intolerance, which has always been a difficult issue to manage for everybody. What we're seeing is these trials initially just took everybody that said I was statin intolerant. The more recent ones are actually kind of saying, prove to us that you are statin intolerant. So they are having double-blind, placebo-controlled statin re-challenges. And what we are seeing is that statin intolerance is a lot more complicated than we thought it is. because a certain amount of patients report symptoms on placebo and on statin. But what we're learning is that not every muscle ache is a statin intolerance, and that a lot of people ache or have musculoskeletal complaints that are not necessarily due to the statin. But certainly for those patients who have statin intolerance and cannot take any other drugs, this is a viable therapeutic option for the majority of them. We obviously also particularly interested in homozygous familial hypercholesterolemia. There has been a trial in the homozygous familial hypercholesterolemia population using one of the monoclonal antibodies. You are getting worthwhile LDL cholesterol reductions in the homozygous population.
So we've heard about the South African experience. Now let's look and see what's happening in the